So today I'm going to start right out going down one of those bunny holes. We're going to be talking about Pleo. If there's some astronomers out there, you may recognize this. This is the Pleiades. Pleo is a Greek suffix or prefix meaning many or more or several. And the Pleiades here are the seven sisters. Sounds like a lot of sisters. My mother actually had 8 sisters. There were nine girls and 1 boy. I was named after that 1 boy, by the way, Thomas Fordham Meggs. I go by Ford. And he was a mortar man in the D-Day invasion. If you've seen the series Band of Brothers, he was in that group. And we were very fortunate to be able to tour a lot of the places that group went. It was an amazing story. Now back to the Pleiades. Why? I mean, this is a heart attack and stroke prevention channel, right? Why are we talking about the Pleiades? Well, it has to do with statins. You know, there's a ton of statin haters out there. I understand that this is not to respond to the statin haters. We'll talk about that. I'm sure there'll be a lot of questions that come up about that a little bit later. This is about the true preventive focus of statins. How many hundreds of thousands of docs are going to talk today about statins with their patients, and the doc and the patient will be talking about this mechanism lowering LDL. Almost all of them. But statins have a very, very different impact. They impact our immune system. They're immunomodulators. That is, the essence of statins. And that's there's a lot of evidence about how statins actually prevent heart attack and stroke by decreasing the inflammatory process of the arteries of our immune system. When we're taking friendly fire, we have plaque in our arteries. Our own immune system is working in there, trying to get that plaque out of that artery wall. It dissolves that plaque, and some of the stuff that the immune system uses, some of the enzymes, some of the things called cytokines, they can cause a clot if they get back into the bloodstream. So despite the fact that we have a lot of discussions about that, there's so many docs that are unaware of it. So many patients, the vast majority of my patients, when we talk about statins, they're thinking of cholesterol levels again. And we use these terms like pleomorphic, pleiotropic. Where does that come from? It comes from the Greek term pleo, which means multiple or more. Pleomorphic, there are plenty of bacteria. Corinabacteria are one of them. Like you see in this picture up here, there are multiple forms. Pleo meaning many or more than, and morphic meaning body shape. So as you can see here, these Corinabacteria have multiple body shapes. Pleotropic, that's what we're talking about today. The pleiotropic mechanisms of statins, where they're really more, in my mind, focused on immunomodulation, decreasing the immune system mechanism of creating hot plaque that can be dangerous and cause a clot if it gets into the bloodstream. So what's today's feature? Somebody thought we were talking about COVID therapy. We will mention that. And actually, the reason that we're covering that article, we're not at all. By the way, you see all these disclaimers these days about any discussion on COVID. I am not suggesting that we use statins for COVID therapy. But actually, the authors of this article did. I was interested when I saw that. And I agreed to go ahead and just discuss that today. Not so much to talk about, is this a great treatment for COVID? I don't really cover a lot of COVID on this channel, but to try to, again, just hammer home that statement that whether you're a statin hater or not, statins are not nearly so much about lowering LDL. Yes, there's some issue there, some risk there, some mechanism, but the bigger issue is prevention. And for that reason, most of the folks that have significant problems with statins really shouldn't. Why is that? Because they're taking high-dose statins, and you don't need high-dose statins to achieve this immunomodulation. So again, we'll get deeper into that when we get into the discussion for today. But first, a few words from our sponsor. That's me. That's us. Previous topics that we've covered. I think it was a week ago we covered, is stevia bad for your gut health? Obviously a big question, a lot of focus, especially with folks like me, and there's a lot of us who have some addictive behavior regarding the taste of sweets. We'll go into detail on that issue. It's a big question. Osteoporosis, is it just women? And are bisphosphonates too dangerous? Again, other big questions for those of us in the boomer generation. There's been a lot of interest in a COVID drug that came up. And again, some people have been commenting, obviously everybody doesn't watch every second of a video. People are seeing that title and they're saying, where can I get that drug? What's the name of it? That drug has not been named yet. It's way too early. It's in the early phases. So we got some content there that you can go back and take a look at. The major purpose of this channel is to chip away at the major killers and disablers in our world. Whether you're talking about wealthier worlds or less wealthy worlds, or countries or societies, the big killers overall tend to be heart attack, stroke. Stroke is the biggest disabler. It's quickly being overcome by dementia. The number one cause of blindness, the number one cause of kidney disease, all actually filter back to the same thing. The same causes. Not all, but only 80%, maybe 90%. And what's scary about that is the science, the evidence is very clear. Your typical docs, as in over 80% of primary care docs, we're not talking about specialists like orthopedists or even cardiologists. Your internists, your family practitioners don't understand how to diagnose this underlying cause, let alone how to manage it. And that underlying cause is insulin resistance, diabetes in the serious level. And most people would say, and I almost went to say, pre-diabetes in a less serious level. Of course, it's less serious, but if you look on a population basis, there are dozens, if not hundreds, of people that have levels of pre-diabetes, but don't have full-blown diabetes. Those people are still burning up their arteries and causing this inflammation that we're talking about. That inflammation, which can lead to heart attack and stroke. So how do you deal with heart attack, stroke, the blindness, the disability associated with all these diseases without chipping away at the root cause? Well, that's what this channel is all about, helping chip away at that root cause. There are several different ways that we're doing that. Obviously, I see patients on a regular basis. As we're getting closer to starting up the Alabama projects, we're going to be closing our panels. We admitted a few other people yesterday, but if you're wanting to be seen, you probably should go ahead and do that. But there are other ways. Unfortunately, you have to learn a little bit more about diabetes and prediabetes than your doctor knows, because again, over 90% of both of these conditions is not diagnosed. If there's one thing I do in my practice over and over again, every day, it's finding somebody that said, no, let's just assume my blood sugar's okay. My carb metabolism is good. My doc checks it every year. Have you had an insulin survey? No, but my doc checks it every year, and let's just assume that it's good. It's like, no, let's don't. No, wait a minute. Let's just do, you're starting to irritate me. It's like, you saw that on, those of you that read the comments saw that interaction with me and one of our viewers just a couple of days ago. It irritates people because they think that this is not a big issue, that they are unusual and don't have a carb metabolism problem. Don't assume that. That's not a safe assumption. And so then going down the path of looking at, okay, what's this viewer, for example, said, well, just tell me what dose of K2 you recommend, and let's assume that my carb metabolism is okay. I'm sorry, but I could not make that assumption. Too many people are dying or becoming disabled for decades because they're assuming that their carb metabolism is okay. So here's one way to find that out without dropping your doc, without becoming my patient on a long-term basis. You can come see us in a webinar. That's an easy way to do it. You get the right testing. You can do a simple way. There's a lot of these courses now. You can often find these courses for free. If you can't find it for free, it's at most $49. In a couple of hours, you can learn more than 90% of primary care doctors about insulin resistance, plaque, how to evaluate plaque, cardiovascular inflammation, some things that we'll be talking about today. The book is ready. June 20th, we're having an Amazon rollout discount. Now, I took the opportunity as we are getting this up and rolling for the rollout to go back and reread it. It's been a few months, and so I reread it with fresh eyes. And I have to tell you, it's not as challenging as I had feared. And maybe that's an interesting description. And I'm the author of the book, and that's an interesting way to present it. But, it's reality. It starts off well. It gets your attention in the premise or the intro and the first chapter. But then I write sort of like I talk. I'll head off all of a sudden down a bunny hole, and you find yourself saying, wait a minute, where is this going? And yes, it gets a little bit technical sometimes, and that makes it even more challenging sometimes to read. But to our defense, to our credit, we didn't write this to become a let's sit down and read this overnight kind of book. We wrote this to help people, to be more practical. Again, to try to help you as a patient interact with your doc and figure out, okay, my doc just recommended a stress test. How did my doc do that? Well, we go into depth and explain Framingham. That's the first thing that your doc's going to do. And Framingham is great. I've used it countless times. But Framingham is not a calculator, it's a guess. And unfortunately, it's called a calculator, and it's clear why people call it a calculator. It sort of, it's a little bit deceptive in terms of implying that we know your risk. It's a guess, it's an estimator. And recently there's a bad guess, at least less of a guess than we would want. I go into the details of why that's the case. There's a whole chapter that talks about it. The result of it is your risk tends to be overestimated with Framingham, especially if you're a woman. And we go into the detail and show the statistics on why a lot of people end up on statins that really don't have the risk that Framingham might have implied. So many people and docs would say, well, that's okay. We're not going to just leave it at that. Well, you know, most people that are on statins are put on statins because of Framingham. So that's not even what the standards committees do. So, or recommend. They recommend a broader discussion. That's not what most docs do. So we also talk about things like stress tests. That's the core theme of the book. It's basically saying, look, people worry about heart attack and stroke, especially heart attacks. They hear about somebody having one, they go to their doc and they say, hey, doc, could we just get a stress test? And this goes into detail on why you really should think twice before asking your doc to do a stress test. In fact, stress tests have decreased significantly during the age of COVID. Now, you would say, well, that was because of COVID, and that's because everything else stopped during COVID as well. Well, my son is a grocer by profession, and he's a grocery store professional, grocery store worker, and he never missed a day of work because of COVID. So, you know, if stress tests were actually life-saving, you would think that stress tests wouldn't have decreased during the age of COVID. ER docs, ICU docs, nurses, professionals, they did not miss work because of COVID shutdown. Yet stress tests bottomed out in many areas. And it's not because of COVID so much as the evidence is becoming clearer and clearer that stress tests don't tell us what we have assumed they should. PC angiogram, I've worded that wrong. Basically, that means a cardiac cath. You go to the cath lab, you stick a needle in the groin, and you stick a catheter up into the heart. So as you can see, we go into detail on each of these activities. Who hasn't had a Framingham done on them? Who hasn't had statin decisions and recommendations based on Framingham? If you've had a recommendation by your doc or a desire to request a stress test, again, this goes into detail on how and why you should be thinking about that. Cardiologists, huge portion of invasive cardiologists make the majority of their income through catheters. This cath procedure, it's actually safer than you might think, despite this imagery of sticking a needle in your groin. I'm not concerned about the safety of the procedure. The real concern is the false sense of security that, oh, you know what? My cath was okay, so I really don't need to change my lifestyle. Or even worse, let's go ahead. You need to have a stent. You put a stent in there, and I've got a stent now. I'm fine. That is the real risk of PC angiograms or catheters, cardiac caths. CT angiogram is a new kid on the block. It really shows you the images of what the plaque looks like in your coronary arteries. It's great for helping motivate you to change your lifestyle. Calcium score, very similar. It is there are pros and cons to it, but a lot of people that watch my channel, for example, watch Ivor Cummins, and Ivor Cummins has been financed for a while by a nonprofit group that's pushing calcium score. More power to them. Calcium score is a great, it's a great way to evaluate your risk. And so a lot of people that watch our channel are familiar with that. Most people and most doctors are not. This goes into detail about the pros and cons of calcium score. We also go into the pros and cons of another study called CIMT. There are, again, pros and cons to each of these, and that is what this book is about. So June 20th, you get a significant discount, And again, don't try to read it all at one time. So let's go to today's program. Statins, are they worth using for COVID therapy? And again, let me just give that disclaimer one more time. I'm not suggesting we try statins for COVID therapy. I'm not even suggesting that we do clinical trials on it. And the reality is there's going to be a lot of that, and that information will come out over the next at least year or so. Again, the purpose is to help underline and hammer that discussion in that whether you're a statin hater or not, statins are not nearly so much about lowering LDL. Statins are more about immunomodulation. Now, this article was in the European Society of Cardiology journal. It was a 2020 review article updating statins' state of knowledge and supports the rationale for their use in COVID-19. Immunomodulatory treatment in various infectious diseases. Although observational studies have reported improved outcomes in patients, there's just not conclusive evidence there. Drugs commonly used for lowering the level of LDL cholesterol in the blood. That's what everybody thinks about statins. But as we said, there's a thing called pleiotropic effects. And the pleiotropic effect in this case is hidden, but hopefully, this is an attempt to start raising awareness. So a self-marker, if you look over at the images on the right, that little bluish purplish thing is supposed to be like a T cell, an immune cell. It's looking for a self-marker. It looks at a piece of tissue and it says, oh, okay, you know what? That's part of us. So it doesn't attack. But in inflammatory diseases like rheumatoid arthritis, psoriatic arthritis, you get this angry looking immune system because it finds a part of our body and it reacts to it. In rheumatoid arthritis, it's a part of our joints. In psoriatic arthritis, it's part of our connective tissue. In inflammatory diseases of the gut, it's in the gut. Sometimes it's in the thyroid. So what happens is these immune cells misidentify parts of our own tissue and they read them as what we call antigens. And they say, you know what, we've got to attack that. Statins have been proven to be beneficial in patients with different autoimmune inflammatory conditions. They decrease systemic inflammation and oxidative stress, the imbalance between production and accumulation of oxygen reactive species. That's what oxidative stress is. And again, that's a whole nother bunny hole we could go down talking about the mitochondria, their use of oxidation to create energy, and the oxidative byproducts that created a major part of the supplements industry. Most of the supplements industry focuses around antioxidant properties, and that's part of what this is all about. But let's get back to this topic, this information. Statins modulate the immune response at different levels: immune cell adhesion, antigen presentation, and cytokine production. You don't have to remember those, obviously. But again, for the geeks, and there are a lot of geeks that watch this channel, a lot of docs, a lot of biomedical geeks. Those are the kind of things that they're interested in: adhesion, antigen presentation, and cytokine production. And it does have a beneficial effect on cardiovascular disease, whether you're a statin hater or not. It's hard to argue with that evidence. Observational studies have reported improved outcomes in patients with community-acquired pneumonia or sepsis, blood infection, when those folks were receiving statins. However, studies on sepsis and ventilator-associated pneumonia failed to demonstrate a beneficial effect. So again, there is significant evidence. There's no question that statins do have this pleiotropic mechanism, a pleiotropic effect, decreasing inflammation. But there's still interest and promise in the context of viral infections, specifically avian influenza, H1N1, SARS, MERS. And again, that's why the issue comes up about SARS-CoV-2 or COVID. Avian influenza viruses, SARS-CoV-2, introduce an intense host response characterized by the cytokine storm, which can lead to acute respiratory distress syndrome, ARDS. That's what puts so many people with COVID, not just mild SARS-CoV-2 infection, but COVID, this serious infection. That's what puts them, this respiratory distress due to the cytokine storm is what puts them in the ICU. Large studies have reported statin treatment being effective in reducing influenza-related hospitalizations and deaths. So again, this is not throwaway, let's ignore the opportunity or the potential with COVID. It's just that I don't cover COVID that much. My major focus here is helping people understand that statins are not what you might think. An association between outpatient statin use and reduction in disease severity among patients hospitalized during the 2009 H1N1 pandemic was also demonstrated. Some immunomodulatory therapies have indeed proven beneficial in patients with SARS, MERS, and COVID-19. Now, based on this evidence, the use of statin as an immunomodulatory, gosh, easy for me to say, huh? As an immunomodulatory treatment for COVID-19 may deserve some consideration. Potential benefits for COVID-19 therapy. SARS-CoV-2 enters the cells mainly through angiotensin-converting enzyme, ACE2 receptors. You remember all that discussion and then that concern that we had early on where there was an article that came out and said, you know, maybe you shouldn't use ACE inhibitors, one of the more recently most popular frontline drugs for blood pressure. As we got deeper into that discussion, no, that was not the case. Yes, it does impact, and the spike protein does latch to the ACE2 receptor, but no, ACE inhibitors are not a problem for COVID. Once in the cell, SARS-CoV-2 causes ACE2 downregulation, thus reducing its protective effects on various tissues. So again, they're starting to show where their logic's coming from on this question. And obviously, yes, it's available, it's low cost, it's safe, certainly safe compared to COVID. Well, I'm not even going to go there. There's so many politics and emotions surrounding this issue. It does provide cardiovascular protection. That also has a lot of politics and emotion around it, but it also does some lung protection as well in these viral infections. Statins interfere with ACE2 signaling. They're known to experimentally upregulate ACE2 via epigenetic modifications. Statins have cardioprotective actions, and they should be taken into consideration, especially with people with SARS-CoV-2 infection. These are the opinions of the author of this study, authors plural, and now you're beginning to see why. These are not so much my opinions. I'm just reporting the science, the evidence, and the opinions that are coming out of it. The lipid-lowering action of statins could treat the hyperlipidemia associated with the use of antiretroviral and immunosuppressive drugs in the COVID-19 infection, and hepatic function should be monitored closely. Conclusion: statins are low cost, available worldwide, even in low-income countries, extensively tested, well-tolerated, adjuvant, in other words, additional treatment, and continuation of pre-existing statin therapy could improve the clinical course of patients with COVID-19. Again, according to the authors, either by their immunomodulatory action or by preventing some cardiovascular damage even as well. New trials could provide evidence of its benefits in patients with moderate to severe COVID-19. So they end, as almost every academic article ends, with a reflection that, you know what, we need to do some more research. I lived in that world, and that's the way I ended my articles as well. I just added this this image from my plaque, the plaque webinar, to go back and help people recognize again. So why are we talking? You know, as much as we've said it, there will be people that are not connecting the dots, and I understand. Why are we talking about immunomodulation for cardiovascular prevention? Short, quick explanation with some images. This is an artery. This patient died of a heart attack, and what happened was the lining of their artery cracked. They had hot liquid plaque in this brown area that leaked out. The hot liquid plaque caused a clot. The clot went to the heart, and that killed this patient. Now, so this hot liquid plaque is a big deal. When you start looking at plaque, one of the things you begin to notice is most people think it's like, you know, hair lining a bathtub sink drain. That's not the case. It's actually LDL and other things that get stuck under the lining of the artery wall, under this lining right here. As you can see, it was under here. Here's another area with hot liquid plaque. And you'll see multiple throughout this patient's arteries. It's a systemic issue. And guess what it's caused by? Too much insulin, too much sugar on a regular basis in the artery. It's also caused by a few other things as well. But the immune system, which we talked about before multiple times, recognizes this plaque and says, you know what, this may be, you know, it may not have a lot of external antigens from it, but this LDL is not where it needs to be. It's not where it's supposed to be. It's oxidized, and we need to just get this out of here. So how does it get it out of there? Well, these immune cells like macrophages, monocytes, polymorphonucleocytes, different types of immune cells squeeze through that lining of the artery wall, come into where this plaque is, and they start releasing enzymes. They start releasing things called cytokines. Those cause even bleeding within this area. They cause more immune cells to come out. They cause release of cytokines. And again, if you get too much of this bleeding in there, you get that, too many cytokines, and this lining cracks. This is what you get. That is by far the most common mechanism of heart attack and stroke. And guess what? It's not just that one fatal, perhaps, heart attack. It's also, this can happen on a microscopic basis, 24 hours a day, 7 days a week for decades. That's how your heart and muscle tissue in your brain and your eyeballs, you know, the back of your eye, and your kidneys, all these tissues, with this process going on a regular basis, can start to look microscopically like Swiss cheese. So the inflammation of heart attack and stroke, the inflammation of cardiovascular systems, is a key issue that's just not managed, not even recognized that well. It's only been over the past decade or so that docs have begun to accept, yeah, that's the issue. I will stop there, maybe go back and refer to some things, but Gilbert, why don't you give us the water ball or whatever that thing is to take us to the next part, to the Q&A. Well, I am getting more of that darn, you know, somebody told me once, I shouldn't say this as a guy who does telemedicine and who has a YouTube channel, but I hate technology. I'm having some problems with the PowerPoint. So let's go in and deal with some questions. A lot of them coming up. E.T. himself, thank you for your thumbs up. And if you would, please go ahead and hit the thumbs up, hit the give us a positive comment. Even negative comments tend to stir up the AI. So even if you didn't like what we talked about, even if you're a statin hater and you said, I wish Brewer wouldn't talk about those, go ahead and hit the thumbs down on that. The AI will see that and say, well, there's something worth reacting to here. Fort Worth West Side, on a related note, script is 40 milligrams of crestor. Too much? You really start getting into a lot of the other side effects that are not good with these high levels. I have maybe 1 or 2 people on a dose higher than 5 per day. So, and I've got some people on 2.5 milligrams once a week. You see, Crestor's got rosuvastatin's got a 17-hour half-life, and it stays in the body for a while. You don't have to take it every day. Again, I'm not, if I'm not your doctor, talk with your doctor about how you manipulate dosages, but I don't use, you don't need those high doses to calm down and prevent cardiovascular inflammation. You need those you need and use those high doses if your target is to decrease LDL. And that's only rarely my target. I have tons and tons of people who have genetic problems with their LDL. It's called familial hypercholesterolemia. Even the vast majority of those, you'll hear a term, heterozygous versus homozygous. In the world of FH, that's not entirely accurate, but it's good enough for it's good enough for proper communications and proper diagnosis and treatment. Your typical heterozygous FH patient just doesn't have huge increase in risk. These people don't die in their 20s and 30s from cholesterol. They start having heart attacks and strokes in their 50s, 60s, when their other risk factors really start cranking up. And we remember what other risk factor starts to crank up in our 50s and 60s. Yes, it's prediabetes. LDL was 137 last test. If so, how do you know what to start with? I usually start with 5 milligrams of rosuvastatin a day, and we adjust from there. And we don't tend to go entirely by LDL level. I mean, that's the whole point of this discussion, to try to get people to wrap their head around maybe there's something else going on besides what your doctor's been talking about. My MPO is 272 and plaque 2 is 157. Maybe 10 milligrams would be fine to start with. Again, thanks for the question. It was great. Fort Worth West Side. I usually start with 5. Eli, the science. Oh, Eli, the science guy. That's definitely an Eli there. Curious to know if I have more than one PCSK9 polymorphism. That's a very informed question, Eli. My recent blood work shows LDL of 30, HDL of 72, and triglycerides of 35. 29-year-old male. Knew that I had R461 polymorphisms per genetic testing. That is interesting. So you're not on anything and your LDL is 30. It's interesting, Eli. You bring up a great point. The PCSK9 inhibitors, like Repatha and all of those, they're little injections you take once every couple of weeks or once a month, and they have a huge impact on decreasing LDL. Not as clear their impact on inflammation yet at this point. I would not depend on them for impact on inflammation, but that's a different discussion for a different time. The PCSK9 inhibitors were a major step forward for pharma. And, you may hate pharma. Most of us do for one reason or another, but also for mankind. And here's why. Here's the usual way that Big Pharma finds something and makes a drug. They find something that works like as a supplement, like red rice yeast or fish oil. The original statins were made out of red rice yeast, and Big Pharma found that. They started working on it and figured out a way to get it patented, their new product, and statins were born. How many billions of dollars have been made on statins? More recently, the group, I'm forgetting the name of the Big Pharma, but Vasipa in the Reduce It trial, they looked at that, and we're hopefully I talked with the guys at Vasipa, the guys that ran the Reduce It trial last week. Hopefully we'll do a quick series on those. Very, very interesting story. And maybe I would love to give you a couple of little previews of that debate between Steve Nissen at Mayo Clinic, I think, and Deepak Bhatt at Harvard, and what's going on with us. Again, let me get out of that bunny hole for a second. Somebody asked me about it later, and I'd love to talk about it for a minute. But Eli's bringing up the point. Do I have multiple PCSK9 inhibitors? I mean, PCSK9 genetic variations, or do I have a different one? Polymorphism is the term that he's looking at. As I was mentioning, the PCSK9s, most of you, when you hear that, you think drug, you don't think genetic variation. So what happened was Big Pharma did a series of genetic surveys. They found somebody like Eli. It was a young female cheerleader who lived in Texas. And they noticed that she had very low LDL. So they got the genetics on this lady and started doing some biological development work. That is how they came up with PCSK9 inhibitors, Repatha and the others. Now, that's a totally different way from the way Big Pharma and mankind has developed drugs in the past. We used to just go out, we'd find stuff that was already working for something and then modify it, and the Big Pharma would make too much money on it. So this is going the right way in terms of the longer arc of mankind. Bambi Gray. Oh, let me just say one other thing before I get totally away from that that bunny hole about PCSK9s. So Eli is mentioning that he's got a variation which causes a very low LDL. Now, I mentioned people with FH, familial hypercholesterolemia. They've got the opposite type of genetic variation. In fact, there are over 2,000 genetic variations that can lead to FH. What is it? Is it like 90? All but a few dozen of them have to do with this same group, the PCSK9 mechanism. PCSK9 is a mechanism where the liver sort of reaches up into the bloodstream, and when an LDL comes by, it grabs that LDL, pulls it down into the liver cell, and burns it. So Eli's got a variation that just burns a lot of it. That's why his LDL is so low. All but a few dozen people with FH, all but just a few of them have damage to the mechanism that does that. That hand that reaches, it's not a hand, obviously. It's a receptor that reaches up out of the liver cell, pulls that LDL down so it can be metabolized. I hope that was an enjoyable bunny hole for some of you. Bambi Grage, hello, how are you doing? Good morning. E.T. himself, me, myself, and I. HMS, thanks, good, okay. Fort Worth West Side. I'm sure the cardio doc is all about LDL levels. Yeah, they are. And that's Thank you for pointing that out. I had to diagnose my own heart disease with coronary artery calcium score 2012. You are not alone, my friend, Fort Worth. Many people have had a cath lab done. 70% blockage in the left ascending. Well, I had a patient yesterday and she came to see me. She had a 340 something in her LAD and 4 in the other arteries. And she was asking, is that common? There's a reason why the LAD is called the widowmaker, left anterior descending. That's the coronary artery that tends to get a lot more plaque. Again, unfortunately, that tends to start taking us down that assumptive mechanism that this is all about finding a plaque. If you find a plaque that's cutting off blood flow, you can put a stent in there and prevent a heart attack. Let's be careful about heading down that direction. Anyhow, but Fort Worth said, but he said he wasn't going to stent it at this time, check in a year. Can't believe I dodged the stent. Haven't had any typical symptoms of blockage. Glad you dodged the stent. The fact that you've got plaque, though, Fort Worth, makes it clear that your body is in a position where it can form plaque now. If it can form plaque, you've got cardiovascular inflammation going on. If you've got cardiovascular inflammation going on, you need to think about a couple of things. Number one, decreasing, having a preventive effect on inflammation. That's when I recommend consideration of a statin. If you don't have plaque, even if you have FH, and I've had a couple of patients like that. Speaking of the book, we tell a story about one of the patients who actually did have FH. She was a statin hater. She knuckled under and was taking the statin, but she came to see us and she didn't have any plaque. And that story helps you begin to understand that it's not having the LDL level so high, because she did have high LDL. It's having that inflammation. She didn't have the inflammation. I didn't tell her what to do. She and I talked about the mechanism. At the end of the day, she said, you know what? I'm going to give the statins a break for a while. So there you go. Fort Worth West Side. What was your personal experience with trying berberine? It helps, but like so many, bergamot, berberine. I get so many people because I did videos covering, and still do a lot of videos covering supplements, and still use a lot of supplements because I'm interested in them. People tend to think, I've had 4 people over the past week say, can I just take berberine or bergamot instead of metformin or a statin? And the answer is, of course you can. I mean, the patient is the executive. When I practice medicine, I'm an advisor. I can write scripts, but the patient makes key decisions about whether or not they'll take a prescription medication. But that's not the real question for the patient. It's an important consideration, but the real question is, Brewer, would you take them? I take both metformin and statins. And I also take plenty of those supplements. So including bergamot. Bergamot and bergamot do have anti-glycemic, some anti-diabetic properties. They also, statins, they also have some statin properties, but they don't have the impact that some of the other medications do. They just don't. Fort Worth West Side, any experience with Invokana? So Invokana, gosh, I'm having a senior moment. Isn't that one of the anti-inflammatories that Paul Ridker used? He did use another one in the Compass trial, and I was wanting to mention that when we were talking about this recently. It was very interesting. I think it was the Compass trial. It was use of what's called a what do you call a child who doesn't have a parent? There's a whole legal class of drugs You adopt the child. Anyhow, they're using that term. The reason they use that term is that it's an expensive drug. There aren't enough people for big pharma to spend the money on researching. So the federal government comes in and adopts these drugs. One of those drugs is an anti-inflammatory drug. They gave it for, Paul Ridker and some of his folks gave it on a global scale to people for heart attack and stroke prevention. And guess what? It prevented heart attack and stroke. Now, it gave up as many deaths associated to increased infection. So they went ahead and tried to get an indication from the FDA for giving that injection. It didn't work. Anyhow, the reason I brought all that up is you mentioned one of these, and I'm thinking it was one of those. So the reason I brought it up was the reaction of the cardiology community when this happened. It caught them flat-footed, and you'd see interviews all over the world. They would say, well, I knew, at least theoretically, that inflammation caused heart attacks and strokes. It was involved somehow. But, then I'd get back to my work and it's all LDL. I was just caught flat-footed. I knew it, that cardiovascular inflammation was an issue, but I did not know that it would actually prevent heart attacks. Duh. So again, we will continue to proceed. We'll get better as a profession, but it'll take some time. NK, Nutritional Ketosis Resources, Fort Worth West Side. I had better results with OTC insulin from Costco. Then I put type 2 into clinical remission, no diabetes meds 1 year. A1C less than 5.6 for the past 5 years with low carb, high fat. There is no, there's been head-to-head comparisons. The point that you're bringing up, I think, is comparing lifestyle, dietary management to medications. This research has been done multiple times. The most recent one was about 4 or 5 years ago in the New England Journal. They did a head-to-head comparison, metformin versus lifestyle. And I'm not talking going keto and all and that. I'm talking just mild, minimal lifestyle changes. The lifestyle changes were 3 times more effective at dealing with diabetes than metformin. So lifestyle is king. Nutritional ketosis and lost 5 inches in waist and 45 pounds. I'll tell you what, if you lose 45 pounds, you're going to have more of an impact than anything, any drug, any surgery, any stent that any doctor can provide you. Ted Joseph, Fort Worth, your calcium score was 2012? Fort Worth, based on 70% blockage, but no stent, can I still start easing into HI? Oh, yeah. HIIT, this is not a destination, it's a journey. I have plenty of people who are post-stent, post-bypass graft, who have major plaque, and they get nervous when they first find out about that and start going into running again or other types of HIIT, high intensity interval training. I have people that their biggest exercise has always been walking on a flat surface in the mall. But, for them, walking faster may be part of their first step of getting into high intensity interval training. You bring up a good point. One of the most important things that someone can do when they have heart failure is high intensity interval training. Again, you have to do it in a controlled environment, but this whole assumption that, okay, if somebody's got something wrong with their heart, they need to stop exercising, stop stressing their heart. Absolute worst thing we could ever do. I changed my lifestyle months ago. No grains, sugars, and less than 25 grams per day of carbs. Excellent. That will have a big impact on your insulin resistance and your cardiovascular health. Yes, I think Westside's saying yes. His score was 2012, and thank you for clarifying, because I think I misread it. I think I was saying you had it back in 2012. Thanks for the clarification. Fort Worth West Side, OTC Insulin at Costco. What is that substance? Personally, I don't know. Bart Robinson. Good morning, Bart. Good to hear from you. I think, Bart, don't you live in New Jersey? Good morning. You're still attempting to make available the home OGTT kit with some form of insulin survey. That'd be wonderful and possibly ease my mind. Thank you. Yes, Bart, we've been working with a group called I'm Aware. It's a lab group, IMAWARE. Gilbert, if you can find something on I'm Aware, maybe a link to them or something like that, if you'll show it. Yeah, so they actually have they have the study, they have the test. For the most part, it's available, but the technology is good. It's similar to the technology used by Meridian Valley Labs, and it's a full-blown insulin survey, not just an OGTT. And you can do it at home. They're not quite ready for prime time. In fact, I did my own and recorded it. And they started getting all of these requests for it, and they started looking around trying to figure out where are all these requests coming from. It was coming from my recording. Again, they admitted, they said, we're not quite ready. Can you take it back down? And so we did. I haven't talked with them over the past couple of weeks, Bart. I know they're continuing to work on it. These things just take a heck of a lot, just like everything else in life. It takes a lot more time to actually execute than it does to have a good idea. Mezzanine, good morning. Good morning to you. D. Dutton, does atorvastatin still have the lowest risk for promoting dementia? Not exactly. I'll tell you what, we're getting tons of questions. I may end up skipping some because it's the way the software works. I told you I hated technology. We'll try to get to as many as we can. I don't understand what you're trying to say. And I don't use atorvastatin. I don't recommend using Lipitor. And again, I saw a patient yesterday who's into digital marketing, and he said, you know what, when you make that comment that, I mentioned a brand name, they're going to shut me down for the AI shuts you down in terms of ad sales. I don't use Lipitor. And the reason I don't is that there are two situations where Lipitor appears to do great in terms of lowering LDL, but doesn't appear to do that well in terms of inflammation. Those two situations are if you're a female or if you have prediabetes. Well, I mean, female alone is half the population, but if you have diabetes or prediabetes, that's the vast majority. That's 80% or more, maybe 90% of us with risk factors for heart attack and stroke. So I recommend and tend to use Crestor, low dose rosuvastatin, 5 milligrams or less, or pitavastatin, Livalo. And that gets complicated in terms of how do you get those? Are they expensive? What are the differences? Why not simvastatin? Why not pravastatin? There's a whole bunch of questions around those. If you have questions on those, I will, ask them and I'll try to get to it. John Tocho, remember to hit the thumbs up, like button. Thank you, John. I appreciate that. Gilbert, if you could show them how to do that, that would be great. What that does, by the way, is that AI, the artificial intelligence within the YouTube machine recognizes this and says, oh, there are some humans that think this is worthwhile. I'll remember that and suggest it to a few other humans. HMS, very helpful. Thanks. Thank you, HMS. I appreciate the comment. ET himself, done in auto mode. Totally clueless what you mean, ET. Mezzanine, thoughts on anti-inflammatory supplements such as NAC, alpha lipoic acid, vitamin D, high omega-3s for inflammation mitigation, etc. Also, foods like turmeric, ginger, and garlic. I will tell you, I use every one of those, or have used every one of those, except ginger, at one point or another. Use, kyolic garlic. I do think there is a place for those. I don't think they replace, nothing replaces lifestyle. And I don't think in most cases that supplements actually replace prescription meds. But, the opposite's true as well. Prescription meds don't replace supplements, especially these type of anti-inflammatory supplements. There is no prescription med that is a replacement for vitamin D. Vitamin D is critical. We've seen it more and more during the COVID outbreak. Omega-3s, again, very important. And maybe I'll have to go down a little bit of that bunny hole about omega-3s, So we were talking about how Big Pharma finds these supplements that make sense and work, and then they try to adjust them and put a patent on them and make mega bucks. They're very, very good. That's why they're called Big Pharma. And that's what, and because they make so much money and what they do, they take a lot. I'm not going to go there. Anyway, so a Big Pharma group noticed that omega-3s do help. And I agree with them. Omega-3s help. But then they started looking at differentiating between a couple of the omega-3s, EPA, eicosapentaenoic acid, and DHA. And I'm blanking on the term for DHA. Maybe somebody can remind me. So here's the debate. On the Reduce-It trial, they used Vascepa. Vascepa is their drug. It is a purified form of EPA, eicosapentaenoic acid, and they got a significant improvement in cardiovascular risk. I've used it. I've had several people that had significant triglyceridemia, high triglycerides, and have used it. Now, I got a call from the guys at the company that make this, and they wanted to present their data to me. It was a great discussion. You see, what's happened recently is there was another trial. I'm blanking on the name of it. It was done by a different group, and an interpretation from another leader in cardiovascular research, a fellow named Steve Nissen. Unless I'm mistaken, he's at the Mayo Clinic. He came out and said, Reduce It was wrong. But Vascepa doesn't help. The reason the Reduce It trial was worked or appeared to work was they had what he called a negative comparison. The negative comparison or negative control was mineral oil. So you had the Vascepa group and you had a control group, and the control group took mineral oil. Nissen's perspective was, excuse me just a minute. Sorry, I got a little tickle in my throat. Nissen's perspective was that mineral oil can create some cardiovascular inflammation. And that's why they didn't see it in the other trial, the improvement. Well, the Reduce It guys are coming back and saying, no, we don't think so. In fact, what we think is you also used DHA, not pure EPA. And the data that we're seeing, and we will show you this data, that data would indicate it's not because the mineral oil in the control on the Reduce It trial was created a negative comparison. It was the other trial used DHA as well as EPA. DHA, although it may not hurt, appears to replace and bump out of the nest, bump out of the mix, whatever EPA you give. So we think that our data would indicate Reduce It was real. The other trial, and hey, somebody help me remember the name of that other trial. The other trial was basically didn't work, didn't show a benefit of EPA because of the DHA replacing it and degrading the EPA impact. There's a good case on both sides of that debate. And again, I invited those guys to find somebody, one of their experts, one of the researchers, one of their consultants to come on the channel. And there's enough there to have more than one video. Hopefully we'll have that. I went down a bunny hole from a bunny hole. So let me go back and make sure. Yeah, I think I answered your question. Yeah, I do use those. Fort Worth West Side, awaiting my craft tests from Meridian Valley. Hopefully we'll be available to discuss results next week. Hope so. Good luck on it. But you know what? Even if you find a bad problem, I remember the quote from one of my patients, a patient who shared a lot of his stuff on this information. He came to me. He knew this space incredibly well. And I started asking about, when I was seeing him, I started asking about carb metabolism. And he interrupted me. He said, "Doc, I've done this a whole lot. My doc checks me all the time. He gets A1C every 6 months. I check up after him. I don't have a carb problem. But I'll humor you. I'll go ahead and check it. We got something very similar to a Kraft insulin survey. And at hour 3, his blood sugar went up to 350. So that I called him when I saw those results. I said, "I'm sorry to hear you say that." And he said, "Well, my first reaction was to be sorry to see that too. But let me tell you something. I feel so blessed, so relieved, because now I know what's been causing my problem. My doc and I just missed it." So I'm looking forward, Fort Worth, to hearing what you find out. Good idea to use fat enzymes to get rid of LDL. Not that familiar with that process. It sounds kind of interesting, but I think I need to know a little bit more about what you're talking about. Bill Boswell, "Doc, in 14 months, my HDL went from 47 to 73. My triglycerides went from 106 to 61. You know, Bill, you sound like one of my patients. You sound like somebody that went from a carb state to a low carb state. I'm taking 1 gram of nicotinic acid daily. Also a low carb, high fat diet. Like I said, low carb went from high carb to low carb, and that will have that kind of impact. Is it the niacin or the low carb? Oh, no, it is not the niacin. I've seen and witnessed and worked with hundreds of people that went either added niacin or alone, or went low carb alone. And it's the low carb that has that kind of impact. Thank you so much for sharing that. That's something helpful for others, I think. Fort Worth, I didn't follow his recommended dosage. I started with 10 milligrams. Thanks. HMS, I wish I could take minimal dose of statins, but I suffer from cramping, and even 5 milligrams of Lipitor no longer work. Took it for 12 years. My doctor prescribed Pravastatin, 10 milligrams. Would 5 be okay? Tends to be, yeah, it does. I've used plenty of 5 milligram Pravastatin. We actually, HMS, we used to use a ton of Pravastatin and Simvastatin. They're both really good drugs. They both have very significant impact on cardiovascular inflammation. The reason we don't use them so much anymore, and the reason we used to use them a lot, had to do with genetics. There's a genetic variation called KIF6. If you have KIF6, some of these work, others don't, and vice versa. That's why you have to start getting into some genetic testing. And at that point, Crestor was so expensive that it was less expensive long-term to just do the genetic testing. 5-6 years ago, 8 years ago, Crestor lost its patent. After 2 or 3 years, typically when they lose their patents, they'll get a couple of competitors. They still remain expensive, but then 3 years from that point, there's been enough competitors come in that the price plummets. That's the situation we're in now. So Crestor works, doesn't matter what your KIF6 status is. Jackie Savoy, do I need more than 20 milligrams Lipitor if insulin is 14 and cholesterol is 250 and triglycerides 139? HDL 43, A1C 5.7 on a keto diet. Well, like I said before, Jackie, I don't use Crestor. I don't use atorvastatin Lipitor for reasons that I talked about. It doesn't tend to have as much of an impact on cardiovascular inflammation. Number two, it especially doesn't have as much of an impact on cardiovascular inflammation if you're a female, Jackie. Number three, it doesn't have as much of an impact on cardiovascular inflammation if you have prediabetes problems. And at a hemoglobin A1C of 5.7, you've probably got, you don't have crystal clear, clean carb metabolism. So, and I'm assuming you're talking about a fasting insulin of 14, optimum fasting insulin is 5 or less. So I can't tell because you're not specific enough in some of the things you said, and I can't give you personal advice over the internet in front of a whole bunch of other people anyway. I can just make some comments. I don't use Lipitor. And the last item about the question that you asked is I've used Lipitor maybe twice in the past 2 or 3 years. It's because of tolerance issues. For some weird reason, those 2 patients could only tolerate it. I think there was some emotional stuff, but the other issue is when I use it, I don't use that high a dose anyway. The 2 times I did use it. Jackie's voice. Oh, and before I started keto, 153 calcium score. Thank you for sharing, Jackie. I hope the information I provided helps you start sifting through the facts that you need to deal with. Rose Vander Regen. I hope I got that right. Try rosuvastatin. I've had no side effects at all. PCSK9 is my next step. I'm still young, so I'm not in a rush. Thank you for sharing, Rose. Calcium score only takes into account calcified. Rose, thank you so much for mentioning that. When we were talking about plaque evaluation, and I did the intro talking about different ways of evaluating plaque, I did not mention the big problem. There are a couple of big problems with calcium score. It's a great test, but one of them is, some people say, well, it's the CT technology, so there's radiation. There is radiation, but for what we're doing, the radiation is not significant. You're never going to see clinical trials of healthy 5-year-olds like you do with IMT, because IMT doesn't have radiation. That's not what I really consider to be a limitation of calcium score. As great as calcium score is, number one, it doesn't show soft plaque. It only shows calcified plaque. I forgot to mention that. We were in a hurry. We're trying to cover a lot of content. Thank you so much, Rose, for mentioning that. The other thing is most of us don't recommend a calcium score more than once every 5 years or so. I have had a couple of patients, really smart, and for good reason, follow calcium score like once a year. Again, the big issue is that it is just what Rose said. It doesn't show you soft plaque. Calcified plaque is not a danger. Soft plaque is. Janice Jansen's, should I worry about pulse of 45? Athlete all my life. Most folks with a pulse like that, that are athletes, it's an indication that they're in great shape. Once you start getting 40 and below, that's an issue. I've had patients, and I've got family members who have pulse in the 40s, not because they're athletic, just because they tend to be a little bit low. Even somebody in their mid 40s, it's something to be aware of. It creates a little bit of added risk in some situations, but not usually. And again, when you say I've been an athlete all my life, especially if you've been an endurance athlete, and especially if you've been managing your weight, both of those things tend to decrease your basal heart rate. Mine, just a month ago, my basal heart rate was like 65. I've porked up a little bit in the latter part of the COVID epidemic. I started lifting more, and when I lift more resistance training, I get more hungry and I eat more. So I'm up to like the low 160s now. My running weight, my healthiest weight is mid to low 150s. And I've started losing weight again. And my pulse, as these things, Fitbits, have a way of looking and measuring and estimating your basal heart rate. I've lost about 5 pounds over the past month. And the Fitbit estimate on my basal heart rate has gone from like 63, 64 down to about 58, 59. So that's a couple of things that tend to deal with heart rate. It's a great question. Thank you so much for it. Rose Vander region, LDL is a good predictor of coronary artery disease. You'd get a lot of people that would debate that. I take berberine as well. Rose Vander tried Crestor 20, but it was worse. Yeah, 20 of Crestor is a major dose. It's more equivalent to 40 of Lipitor, and I don't recommend going there. Josefina Lopez, good morning. If my doc is willing and supportive, what's the best diagnostic test he can provide to me to determine buildup of plaque? Well, I would say, first of all, get the book. You'll figure a lot of that out. I tend to use 3 things. The thing I use more than anything else is CIMT. But like all of these, every one of the studies has its good points and its bad points. The good point about CIMT is it will show you if you have inflammation, if you have soft, hot, inflamed plaque. It's the only one of these tests that does that. The other 2 that I use are calcium score and occasionally CT angiogram. So I really recommend thinking twice before you get a stress test, and especially a cardiac cath. Bart Robinson, Amarin Pharmaceuticals, Vesipa. Oh, thank you so much, Bart. I appreciate that. Amarin, and then Amarin, I think, partnered up with one of the known big pharma groups for production and sales. At least I think that's some of the guys that called me last week. Orphan. Oh, thank you so much. They say word finding problems is one of the first problems you see with impending dementia, and I may have that, but here's the issue with me. I've had word finding problems since the 4th grade. I noticed it then. My daughter and wife, my daughter's home from South America, and she's visiting. She and Janice both are big crossword puzzle fans. And I always hated crossword puzzles. They seemed like the biggest waste of time. I remember riding on the train from Larchmont into the city when I lived in New York. All these people doing the New York Times crossword puzzle. Resisted it from day one. Played all these other games, to help prevent dementia. Mostly physical stuff helps prevent dementia, but that's a different issue, different bunny hole. Because it was my daughter this time, I agreed to go ahead and start trying crossword puzzles. And now I'm realizing why people like crossword puzzles. They can help you exercise that word finding stuff. So I'm really starting to get into crossword puzzles. Hopefully you'll see it in my performance on the channel. I won't spend so much time lost looking for words like orphan. For those of you who are not connecting the dots, I mentioned the drug that Paul Redker used. It's canakinumab, I think. I can remember a word like canakinumab, but not orphan drug. Invokana, I think, is the other name for canakinumab. It's an orphan drug. It's used on some things called infantile, I think it's infantile fever, something like that. Going into another word finding problem. But when I was telling that story about canakinumab and Paul Redker's research and the fact that when it actually, you give it by injection, you gave it every quarter, and it actually decreased heart attack and stroke, and how that just caught the cardiology community flat-footed. They were saying, I knew, at least theoretically, inflammation had something to do with heart attack and stroke, but this caught me flat-footed. I did not expect it to actually prevent it. That drug that I was talking about, like $250,000 a year, 4 shots, one shot each quarter. Very unusual indication. Not too many kids had that problem, that inflammatory problem. So it was an orphan drug. That's what E.T. himself is telling me. Thank you so much, E.T. Jackie Savoy, don't statins cause memory loss? Yeah, there's a perception that it causes memory loss, but I forgot what the other problems were. And yes, I do take statins. Now, when you look deeper at memory loss, you make your choices. I personally, like I said, I do take and use statins. I personally knew that I had plaque from some CIMT activities and some other activities for about 3 years before I finally personally broke down and started taking statins. So I'm an anti-drug guy, even though I do use them. And, we all make our choices. Now, blood sugar. There's a statin called pitavastatin. I mentioned it earlier, Livalo. Livalo is the brand name that's available in the U.S. It has the major advantage of not causing insulin resistance, pushing you down that diabetes highway. Now, you got to go back and you got to take a cold, hard look at how much risk are statins and which ones for increasing prediabetes, the major cause of this problem. Again, if you're using 10 or 20 milligrams of Crestor, you are pushing yourself down that blood sugar highway. 5 and less tends to not have that much of an impact. We have the drug that I just mentioned a minute ago, Livalo, is now in that position that Crestor used to be in. A great drug, major advantages, but still on patent, so still very expensive. The major advantage that Livalo has, it has fewer of the other side effects, but it also has it does not cause insulin resistance. It's expensive because of that. It's that battle. The big pharma knows they've got a great statin with far fewer side effects. So they charge a lot, and they still have it on patent, so they charge a lot more for it. The insurance companies know that, and so they will say, look, we're not going to pay for pitavastatin unless you've tried the other statins and you have major documented problems, et cetera, et cetera. So again, Jackie, thank you so much for the question. I'm sure I gave you more than you were maybe asking for or wanting. Rose Vander Roden, sorry to hear that. Helps with inflammation. Old Roscoe, thank you, Roscoe. So we're getting a lot of those comments. Yes, orphan drug. Seems like many people can't tolerate statins. I wonder why. I have to tell you this. They've done studies. It's clinical trials with people that, and I'm not saying, and these authors weren't saying this either, but what they did was they took people that were, quote, could not tolerate statins, and they did a clinical trial. And obviously they mixed it up and blinded it regarding whether or not they could take statins. And the vast majority indicated that there was more fear there than there was reality. Fear is real, though. And again, nobody's saying that statins don't have side effects. So take statin side effects seriously, deal with them, don't ignore them. That's what we keep having to train doctors to, the attitude to take, because most of them see and hear this data and most of them think, well, it's all in your head. You can't do that. But again, these lower dose statin, that's one of the major advantages of using lower dose statins. You don't get nearly as many of the side effects. Fort Worth West Side, the left anterior descending artery is 861, left main 66, left circumflex 116. You're not alone. I've seen very few calcium scores where LAD was not by far the big one. That's why they call it the Widowmaker. Right coronary was 959 on calcium score. The well, you're one of those where you had another one other than the LAD, which was a little bit higher. The 2012 score was a total, just FYI. Thank you so much, Fort Worth, and thank you again for clarifying. It was not in 2012. It was your total score of 2012. Thank you again for that detail. And thank you for sharing that with others. As you see, there's a lot of people that are very interested and concerned about statins and are appreciating learning about them. I also do, Bart says I also do well on 5 rosuvastatin, no muscle aches, and I work out hard. I do too. I work out very hard, and it was interesting. I did have some reaction. I don't know if it was the statin or not. I was on 5 rosuvastatin for years and still on it. There was this hill that I used to run behind my house when I lived in Nashville, and it was like, not straight up, but it was a lot more than a 10% grade. I think it was probably a 25% grade. It was a great way to finish a run. I did it once a week. And after that hill, I would always start getting these cramps in my right calf. Same place, same cramps, same place on the hill, actually coming back down. And that happened for over a year, once a week at that one place. I, just pushed through it. I would walk through it and it would go away. That creates a whole different set of questions regarding, well, what are these cramps? A lot of people see them associated with statins. You can't say that statins don't do that. There's enough evidence that they do. But there's also evidence that a lot of other stuff does that. I would recommend that you try some significant magnesium replacement. If you're having those, I would think twice or more about stopping the statin. So many people stop statins because of stuff like that. And I don't think that's a great idea. Jackie Savoy, I do take 500 milligrams of metformin. Thank you, Jackie. I do as well, and a lot of our folks do as well. Gosh, folks, it is 12:30, and we've got tons of questions. I'm going to have, actually, I apologize, but I have 4 patients coming in this afternoon. The next one starts in about half an hour. Great. We got lots of interest and attention. I tell you what, if I didn't get to your question, you have questions that you want to get out there. If you would go back to the video, this will be posted and available on the YouTube, on the internet, and just write it down again, because they'll tend to drop most of these comments and questions now. Thank you so much for your interest, and hope to see you next week.